primarily focuses on the impact of early life exposure to environmental contaminants, including plastics and plastic associated chemicals, on metabolic, reproductive, and developmental outcomes. Dr. Basak has been an active researcher for 20 years covering nutritional biochemistry, developmental physiology, metabolism, and nutriodynamics, and has published over 100 articles from original research, reviews, editorials, edited books, monographs, and book chapters. He is responsible for academic and teaching activities, imparting training, and guiding young researchers for the PhD program. Dr. Basak is an ad hoc peer reviewer for several international journals and has reviewed over 500 articles. I'd now like to invite Dr. Sadhana Joshi, Dr. Chitranjan Yajnik sir, and Dr. Vinaya Vaishampayan to felicitate Dr. Basak. So may I request you to come on the dais to felicitate Dr. Basak sir. This is slide. Oh, kill me on.
Here in our staff meeting and here at the same time, so you're giving our blessing and carry on. Thank you.
So would you like hand mic or this mic is fine?
Either of these.
Either.
Yeah, if I find it there. So, yeah.
What?
Yeah. Good afternoon, everyone. And this is something, after a lunch, your melatonin will be secreting, and from the tryptophan or whatever the food you have. So I think you have to keep little bit. And I want to tell just a different topic, but in a context, obviously in the early developments. And today I'm trying to highlight the one important aspects, a part of that environmental risk factors, or you say that environmental lifestyle changes and the exposure. So that plastics is something as such we consider this as a material, but it's more than a material. Plastic is actually. So think about that our National Institute of Nutrition, how does it connect to the plastic is something one can ask that. But when you're seeing plastic, we are thinking about food contact materials like FCM, which is popular. And then it comes around a different perspective, and which essentially is very, very difficult to assess the actually risk in a life course of 60 or 70 years of the humans will be exposing. And that the plastics and EDCs, like endocrine disruptive chemicals, are very often connected. The reason for that, that this plastic contains that leaches out into that from the substances when in a touch, and then that internal hormone systems may be thousandfold less, but it mimics, that. So when we talk about that materials of the plastics, it has a list, huge, which is out of the scope of this meeting. But for the general, you must be knowing about this couple of terminology like bisphenols, which is very popularly known as BPA. Then you have a phthalate, is a molding agency in the plastics. Then flame retardants, toxic TFAs, and then you might have the encounter of the BPA free stuffs is written. Actually, BPA free doesn't mean EDC free. And then you have a BPA free product level is substitution of other of the BPA. There are many isomers of the BPA. So I think that the reasons for here this meeting is that obviously we're talking about the early developments and others. So we have actually a huge, data sets having genetic predispositions, poor nutrition, physical inactivity. All these are the genesis of that. But I don't know whether these are enough risk factors to explain the rise in obesity and metabolic disease. That we need to be really think about it. And environmental risk factors are in the limelight, and you have a lot of papers, like environmental risk with the cardiovascular risk, with the air pollution, PM 2.5, many. And then obviously I already told that it leaches and it matters. And then it's the ubiquitous actually. If I will show later part that from the not only food, air, contact, everywhere. And also, I think Dr. Mohan's group, I think long back in 2015, they measured in the diabetes in that level and tried to correlate, and they found that it's higher in that. So it was sort of associations. But the primary things from that inside this, they basically that if you see there as a effects, like when that binding to receptors is the important that estrogen receptors, which is that basically the mimic that most of this, those are EDCs are, they actually change that internal cellular response through the series of that hypothetical. It could be 1,000 less, but it happens inside the cell. There is a lot of evidence even, and we try to, dig out of that issue and that how much exposure we can get, and we are, in fact, we are trying to assess that urine samples from the DMARD guys who are exposing the thermal receipt every day because he is a chipping one, and in the thermal receipt is one of the source for that. And radioactivity studies from the skin also have found in Canada that expose a certain amount in the blood in that. So as these are the trying to say that, just to emphasize that the roots and their sources, their effects, and the down where I'm trying to show the arrow, it is based on all animal models. So the risk which you are stating the down is basically either is the animal model, or you may find some associations in that blood level that maybe there are some. So so actually this since as I told that it's a perfectly fit to that that actually if you see bisphenol has been actually brought into that estrogen disrupting compounds way back 1936. Edward Charles published in Nature, and it's almost 80 years. But then the thing is that everyone knows it. But the concern comes with that when this is, if you overlap their exposure at the critical window, and that is something which we are trying to mimic that to assess the risk, if not in general physiology in the adults, with their exposure during the developments. What is there any greater risk for that? That is the area where we actually started in way back 2015. And then we propose that because of this data, this bisphenol A, bisphenol S, phthalate, all are there in the maternal pool in that this disease. This is there. But the rest of the things is hypothesis, like what we propose in way back 2020, that it might change at the internal hormonal systems, even during the pregnancy, in the placental hormones or the mothers, because of the risk and exposure. It is a very hypothetical, but it exists that because the association studies are there, which I'm not showing here because of the lack of time, which will be mostly focusing that assessments of the risk. But if you see that little bit chemistry of that, estradiol is a mimic that bisphenol A, one of the heaviest, like used the plastic materials. It's almost a binding affinity to 1,000 to 2,000 fold less, and it's reported to interact by several of these receptors in the androgen receptors, estrogen receptors, and other many other receptors, PPR, XR, to have that impact on the potential impact on the metabolisms. So now what these substitutions, if you see when the product is written the BPA free, basically what does it mean? Basically, that mean is this is replacement. Where there's a BPA free means this. That means is basically the methyl, which is very reactive, is substitutes by this, the sulfur. So essentially that is the change. But if you see hydroxyl group, which is the much more reactive, it remains same. So that's whether the substitution itself has any reduced risk need to be assessed. So even if you wanted to assess this risk, you need a model. Because I can't do it in human. It's ethically not possible. So what you need to do is definitely a model. You need to adopt that to risk. And if you see that in the human, once BPA we have taken up, and then it convert, we have in the liver systems we have a catabolic enzymes, and then it convert to the inactive like BPA glucuron, which is inactive, which is not hormonally active. So it will essentially it will excrete within 24 to 48 hours and it will be there. Now, but in case of rat, there is an extra step because it has a enterohepatic recirculations. That means your residual remaining of this is much longer than human. So for risk assessment, this could be one of the good model if you wanted to have this one. So at the same time, if you further consider is a model, here if you see the red mark, where is the BPA is entering inside, I'm talking about this is in rats during the pregnancy. It will go and to the liver, mother liver, then red is a BPA, then converted to inactive through UGT. And once it is devoid of, that activity, that endocrine activity, it pushes through the fetus to the placenta, it crosses to the fetus. Now, once it releases the fetus, actually again, these enzymes, which actually deactivate, is not there in fetus. So that means during that exposure window, fetus is vulnerable to expose directly to the free BPA, which has some endocrine activity. Now, here that can make us a change in the target organ, those are developing during that. So this is the point where is the additional risk I'm talking about. So then the problem was there with us is that how to define the risk dose, like how we'll assess. Now during that time, EFSA, a European Food Safety Authority, actually set a tolerable daily food intake at 4 microgram per kg body weight per day. This is a tolerable food intake. So what we try to take this tenfold high, tenfold low about these doses. But before that, what we're trying to make the assess that if that BPA is, if we take the BPA and inject to that through orally or through inject as a drug, what is actually happening to them? Does it have the metabolize that? So what we do a small experiment pilot to give oral gavage as well as intraperitoneal injections and collected blood in different time period just to see that there and then detected BP in the serum. So if you see this is the data which 0 hours that from 0 to 2 hours when we injected interperitoneally this BPA at the serum level shoot up, and that means first pass metabolisms which is typically happen through the oral when you any drug when you take that it actually takes up to 2 hours, and after that it actually reaches, so we could detect around 148 to 177 nanograms per ml. So that indicates that there's presence in the systemic circulations. So once we confirm that, then we did a design a study, and here that doses and the group, essentially I will tell is in a short that the major in here exposure risk only during the pregnancy, during that animals, during gestational day 4 to 21. Rest of the period, rest of the things are everything's are normal. Animals are absolutely with that normal chow diet. We did not change anything except we have given BPA to this development. And why we left GD4? Like we left 4 days because we did not disturb that implantations, and that is the what we spare that so that let it develop. So after that we expose that, and our assessment was way later, around 90 days 30 days onwards, where we have been given the animals in the normal diet what has to be. So and then we try to see that each impact starting from that metabolic changes of this offspring. And remember that these offspring, each mother has been almost 8 to 10 pups. So we have to have almost, and there is 7 groups, at least 10 to 15 samples per experimental group, which we will be showing the data after that. And once we wanted to first we wanted to see that mother changes. Is there any change in the mother body weight of that? But there is no change in the mothers. But that if you see the body weight in the 21 days pups, there is an increase, significantly increase, and in particularly male. And then what we found, try to see if maybe they have taken more food, but actually there is no change in the food intake, so it's same, there is no significant changes. But if you see that that morphology, gross morphology, whether it's controls and bisphenol, this has been taken in the lowest dose. That means tolerable daily intake was 4 micrograms, but this was that group which has been taken a tenfold less. So calculating that, you have 1,000-fold less in that receptor mimicking activity. So we have taken tenfold less and try to show that is a gross morphological changes, because it's sort of we also have a little bit surprise on seeing that. So this obesogenic effects, we try to find whether it's an error or maybe one-time point. So what we did, longitudinal assessments from 45 days, 60 days, 73 days, so different stage, and try to take the body weight on those animals, and also subjected to all animal to the DEXA. And what we surprisingly see that the huge changes in the body fat distributions, in particularly fat mass, fat percentage, and in addition to that body weight gain. So then we try to find out that what could be the reasons, especially that if it is feed efficiency. Yes, there is some changes in the feed efficiency, and obviously another important thing is leptin. So leptin dysregulation is also observed, and you can see that stress, like our observations was there, those offspring are just moving faster, always be overactive. Those are exposed to that mother. So they are stressed, and then cortisol level, if you can see that, this much higher than the control. And then we have tried to find different organs and liver weight. Then these are the red mark is something which found a significant changes in the spleen, liver, and testes, and their size has enlarged, and liver. So then further we try to see that much changes in the subcellular level. What is happening, if it is that, what is that adipose or adipocyte changes and adipose histology. And if you see that from the compared to the control, BPA group has adipocyte hypertrophy, that's larger in size. That means it might have accumulated more lipids inside, and that could be the one of the reasons that their larger weight and that diameters. So it is whether you take BPA or BPS. BPS means substitution of BPA, doesn't make any difference in that as far as adipocyte size are concerned. So that means adipocyte hypertrophy was almost equal. Now, this was supported by different several other factors. Those are subcellular factors, so that the proteins, those are actually responsible for that intracellular lipid transfer, and especially fatty acid binding protein, PPI gamma, these and HSD11 beta 1, these are the one which controls the liver metabolism, fat metabolism. So if you see that their expression level actually dysregulated from the normal, so there's something wrong in that metabolic outcome of that offspring. Those were actually born to the mothers. Those mothers were exposed, particularly during their developments, with the bisphenols. So then, in addition to that, what we observe also, there is a inflammations, increase in this adipose tissue. So, adipose inflammation and another uh, phenotype, which has been a obesogenic phenotype. And if you further what we try to find that liver, and if you see that liver is the color, what we observe, the liver color has been changed in case of exposed to this. There is absolute liver weight increase, but when we rationalized with this body weight, there is no change. But the color is actually changed. Now, if what we did further histology, what we found is there's a hepatic fat accumulations in the liver. Although the liver triglycerides and liver uh, total cholesterols remain insignificant, but there is an upward trend in both the occasions with this exposure. Now, actually, as I told that we try to propose that hypothesis or sort of to explain this phenomenon with the mechanism, and where that this leptin resistance then enlarge adipocytes with this inflammations can have attractor of neutrophil and then macrophage activations. It could possible there is a M1 M2 kind of switchover, and to that leads right to local systemic inflammations and accumulations of the liver in the lipid, a lipid in the liver, and then followed by inflammations, and that might have resulted in microvascular steatosis. I think these are the one which we try to propose, but it need to be validated some other studies. Okay, so then we try to quickly wanted to see that body compositions, because there we found some changes in the bone metabolisms, and that bone mineral contents and the density, those are also actually increased. So that means those animals having a different kind of skeletal muscle parameters than the normal animals, and it actually supported with several other factors, whether the IGF-1, calciums, and osteocalcin and alkaline phosphatase. So I think that was the one which we try to emphasize that. So usually estrogen is that which controls the bone metabolisms, and if it is bisphenol is estrogen mimicking, is that the doing that the similar way. So I think that way we try to propose that another mechanism is possible, that it what way, and a lot of other mechanistic data we have, but because of this lack of time, actually I'm not showing that. But in general, what we found that I think it's a BMP signaling pathway that has been some, could be one of that involvement in that ECM synthesis and subsequently destabilize the bone homeostasis. So to assess that, other important aspect is that because people says about the plastics and fertility, especially male fertility, is a lot of topic there. So we just wanted to see that reproductive functions of those offspring. The reason to evaluate that reproductive functions, if you see that our human developments is the male reproductive tract is a blue color, showing that it's a spanning from this, first trimester to almost, that is the range where the development happen. So there is enough chance that exposure risk falls overlap with this window, and data are already been there to associate the several risk factors for this male infertility with BPA level. And what we try to see that anogenital distance of the male offspring. What we found that, and that shorter anogenital distance is the risk for male infertility. And if you see that BPA exposed rat has a shorter AGD, and obviously the testosterone level is also dysregulated in this. If you see that plasma testosterone here. Now, I'm not going to detail about this because this is the supporting data. Just we need to confirm our phenotype. It's really happening or not, or is an error for our assessments. So we try to see the lot of receptor expressions just to see if you are wrong or we are right. So that actually falls in that, not only one, two, multiple, we just to confirm that. And further, what we try to see that actually what's happening in that spermatogenesis events. Don't know if you see the cross section of this. This is a testis histology of those animals. Those animals actually, and if you see the left control, spermatogonium is a very uniform, structured, but whenever the BP is there, you see there is a elongated, and same is the BPS. There is absolutely no changes. That means it affect that actually core of that spermatogenesis process at that development process. Now, in addition to that, what we're trying to see that sperm DNA damage. How do you assess that? This simple acridine dye orange, when you use that, this sperm, if it is the top of the head with an arrow color, if it is showing green, that means it's a healthy sperms, motile. When it is orange, that means those are unable to move properly. And then if you see that BPA and BPA exposed group, there is a much more number of the orange kind of sperms compared to the control. So actually oxidative stress is the reason, causes majorly the sperm DNA damage. More details are here. I think if you have time or if you are interested more, so you can find it. Other important aspect is the sperm motility is driving by fatty acids. I mean, I'm the lipid guy and I always come back to the lipid. So here what I wanted to show you that the left side is a rodent testis. I mean, either omega-6, I mean, major fatty acids in the testis, and right side is the human. And if you see that in the testes at the endpoint, in case of rodents, it's a DPA, like docosapentaenoic acid, which plays a role for the DHA, which is for human. Now, for this time, that infertility or infertile men have a less DHA in the sperms. Quickly, I'm trying to tell you. So, just to have this one, what we're trying to find, we extensively analyze these testis, these fatty acids. What we observe in the BP exposed group, there is a rapid, change in this. Is a long chain fatty acid in that, especially DPA, docosapentaenoic acids, that, and other obviously arachidonic acids and other. And this is something which is absolutely different from control, and even in the low doses of BPA also did not have such changes. So even if you see that human, what I'm trying to show here, these slides, in case of human DHA level, in a control like normal, it's a different classifications of the male fertility status. Some of the sperm is mobile, some is immobile, so different terminology. I'm not going to detail about that. But what I'm trying to emphasize here, compared to the control, DHA level in the sperms in infertile men less. So is our study. What we observe is that in a DPA level, also less in the rat sperms. So this is something which try to find that, and not only that, we try to follow it up with a different kind of modulators. Those actually endogenously convert this fatty acid, especially fatty acid desaturases and elongases and others. And if you see that their expression level also actually modulated with this in these animals. Now, further, we try to find that FAD-S1, which is one of the important for converting this endogenous conversions of this. And in the control, if you focus on the merge, then it is green glow is much more concentrated and condensed, whereas the BPA exposed, testes, there is a dispersed. That means they are not only localization, their expressions, both are actually dysregulated. So we'll find much more here in this paper. So I think what we are trying to emphasize now, we have a generational aspects here. What I'm trying to emphasize here. So if BPA has been given directly to the male, it has a series wise, I mean, generation after generations have some changes people around the world is showing. Sorry. Sorry. So what I'm trying to say here is that it's a multi-generational, transgenerational effects, especially through the changes in the epigenetics, because one of that BPA structure, if you see the methyl group is present in that, and there is always chance that it causes the epigenetic changes. So now, since we are talking about that EDCs, then now has come a greater risk with the microplastics. And if you, I'm sure that people have been there in that, and it's a really talk of now everywhere. And we are trying to get into it that what is exactly is that some nomenclature about that micro, mega, based on the size of that, but that the major challenge is the microplastic is the detections and the capacity and that infrastructure is needed. So here, just to have that, I'm just sharing this as a materials. It is being there everywhere, and based on their size, they have a classified, and you can have. But what I'm trying to show here that value is something has been actually from the this has been taken from the human, from the deceased human organ, and then measured that each organ how much microplastic is there in that. So these are the size which has been showing in each of this arrow actually is that how much is it detected in each organ of the particular adult human. I told you, said three arrows indicates a different route of exposure, whether injections, inhalations, dermal. So what I what we are trying to propose, definitely it is going inside, and it might internalizations, it help in internalizations or induce different internalizations of the protein. And particularly, I'm sure about the change in the gut. There is no doubt about it, but we need to prove it to do very early. What I try to first wanted to see that microplastic in our eyes. We do not have any, detections there, except same. What we did, we purchased some microplastics from the synthetic polystyrene microplastics, and then the first slides, if you see that native one, how microplastic looks around on the first three, 1 to 3, then the vehicle means it's here the cells. We use placental cells, and then different concentration of microplastics. If you look very carefully, each particles is is not that something in the outer side. It has been embedded inside the cells. That is, it must have replaced with some of that internal protein or their functions. So, and also we've found that in the model that we used it invasions as one of the trophoblast invasion is a key factors for placental successful placentations. So use this particularly microplastic, and what we found is trophoblastic invasions, migrations, all are inhibited is that exposure, possibly by different other mechanisms, and we are trying to extensively we are trying to analyze those stuff right now. So since I'm going to close this, sorry for my throat irritations. Last couple of I was not sure about to attend this meeting before I come, because really in Hyderabad in winter I got this one during the last month travel. So, but fortunately I'm ending in that. What I'm trying to show here is a matter of sensitizations is needed. We as a scientist we can't do it, but some way media comes us and to tell about our story is better. In this case, they came us and try to tell to all others. That's why I'm sharing with this, and because at the end of the day, it's the more you sensitize, and you need to involve the media to tell that then investigating journalism is something which helps a scientist to have this kind of issue where uh, government alone cannot do unless people approach for that. At least if we wanted to segregate the risk means the physiology of that risk, whether it's the adults or the pregnancy. So I think then if you see that the pregnancy is the exposure window where I think the risk is maximum. So if you making more awareness, and that itself maybe minimize that exposure risk, it will be a greater effect. Even it will be very extremely difficult to make a designing a study with this bisphenol exposure. Then you need to go back to get the samples where plastic was not there, which is impossible. It's not possible because you won't be able to find any control samples in this case. So what will be eventually you need to have to go back to when before the plastic was discovered, which is also not possible. So what the other way is to sensitizations is the better way, and to have a trade-off balance wherever it's necessary and wherever we can minimize the exposure. I mean, that is the way we can do it. So thank you very much. If you have any questions, I will be here till 7. I can take you.
Thank you so much, sir, for bringing light on the impact of early life exposures of plastics and on metabolic and reproductive health. Now we move to our next session. Our next speaker will be Dr. Rachana Pavaskar, Assistant Professor, Community Medicine, BKL Valvarkar Rural Medical College and Hospital, Savade, to speak on life course undernutrition and diabetes. Dr. Rachana Pavaskar is an academic and clinician with expertise in nutrition-related metabolic disorders and life course health. She has extensive experience in teaching, clinical services, and public health research with particular interest in life course health, undernutrition, non-communicable diseases, preventive oncology, and health system strengthening. Dr. Pavaskar has been associated with nationally important institutions including KEM Hospital, ICMR Nari, and has served as a nodal officer for multicentric national studies. As an accomplished researcher, she has received several prestigious awards and has been widely published in peer reviewed national and international journals. Her work reflects a strong commitment to translating research into community and policy impact. I'd like to invite Dr. Sadhna Joshi ma'am to felicitate Dr. Pavaskar.
A very good afternoon to one and all. I want you to clap aloud. Thank you. And the claps are not for me, they are for you because you have been patient listeners all through. So before I begin, I want you to remember the hungriest you have been. खूप जोराची भूक लागली होती. आठवलं? Not peckish, not skipping lunch, but a deep bodily hunger. The kind that makes time slow down. कधी एकदा जेवण मिळते असं झालं असेल ना कधीतरी? Now imagine that hunger is not for a meal, but for a future. This is the story I bring to you from the villages of Konkan. It is not a story of calories. It is a story of biological betrayal, where the body's memory of starvation becomes the blueprint of disease. As Dr. Yajnik sir said that there should be someone from the Department of Community Medicine to propose these ideas, and here I am standing in front of you. So let's start with the story because I always integrate storytelling into my lectures for my students. So yes, I have a story for you. Let's start it with diving deep into the history of Derwan. So Derwan जर अवघड वाटत असेल तर चिपळूण सगळ्यांना माहिती आहे? येस. तर चिपळूणच्या जवळच आहे डेरवण. Exhausting in weighing the basic needs of life, health definitely saw no room in their lives, leave alone taking it as a second fiddle. त्यामुळे हेल्थ दुय्यम असं नव्हतंच त्यांच्या कधी आयुष्यात, कारण त्यांना जेवण, पाणी आणि वस्त्र म्हणजे कपडे घालायला ह्याच्या पुढे काही आयुष्य दिसतच नव्हतं. अँड देन असं एक पिक्चर आहे डेरवणचं की खूप सिनिक आहे. इट इज व्हेरी सिनिक विथ लश ग्रीन, टॉल स्टँडिंग माउंटन्स, bountiful rice fields, nice scenic beaches, but that all together has a different story to tell all of us. The mountains that isolate, the rain that drowns the crops, a faith in traditional healers so deep that modern medicine seemed a foreign language. Poverty here isn't just economic, it is ecological, cultural, and generational. So to understand non-communicable disease, especially diabetes, better, we must first understand that medicine had to become anthropology. So our first intervention wasn't a drug, it was trust. We at the Valavalkar Hospital, we built trust and rapport through community service, which has been the core value of the Sri Vitthal Rao Charities Trust. So, and then the hospital was formed, which was the first baby step that we took, where we integrated the social medicine component into care, cure, delivery. So, and now the campus, this is how it looks after 29 years. It is a nice campus stretching over acres in Derwan. So it's a we also have a medical college there. So what extra did we do in the villages so that we could make an impact? How could we help penetrating our strategies, medical strategies into their lives? So we spoke the poetry that they understood. We named our nutrition schemes after Lord Krishna's beloved Laddu Gopal Yojana. Our pregnancy care after mythologist's greatest nurturer, Yashoda. We didn't fight their culture, we medicalized the metaphors. As I already mentioned, we now have a medical college there and also a research wing wherein we cater to adolescent health. We have the Day 1 cohort wherein we are longitudinally following up the adolescent females. We have the women's health wing under nutrition and its links to diabetes and cancer and NCD screening with Tata Memorial Hospital. So yes, that this was actually our bridge, and across this bridge came truths that shattered our textbooks. So these are our people. Meet our people. This is our paradox. By every scale we know, they are very deprived, but by the metrics emerging from their blood, they have been grappled with diabetes. So how this can be true? This question led us to a detective story that rewrites everything we know about the metabolic diseases. So when we compared what we saw in the OPDs versus what we saw in the community was the same. The people with low BMI, that is the people who were underweight, were coming up with NCDs, predominantly diabetes. And that's when we were prompted to look back to have a retrospective study into our minds. So then when we followed up, we saw from pregnancy until the adulthood, we saw something very grappling. The first crack in the reality was that we expected to find malnutrition. We did, but the hidden within it was gestational diabetes mellitus, 20.3%. In the women with no overweight, using stricter criteria, we found that 32.2%, that is 1 in 3, had gestational diabetes mellitus. Science is an art of listening to what the data screams. And this data was screaming, your definition of diabetic patient is going wrong. These women weren't overfed. They were undernourished in utero, undernourished in childhood, and now their exhausted pancreas could not handle the metabolic demands of creating new life. So these are key drivers of gestational diabetes mellitus. So as we can clearly see, we are mostly familiar that एखादा कोणी जाड असेल तर त्याला डायबिटीज असू शकेल हे आपल्या डोक्यात एक प्री कन्सिव्ह नोशन असतं. पण ह्या ज्या फिमेल्स होत्या ह्या अंडरवेट होत्या, त्यांचा बीएमआय ही कमी रेंजमध्ये होता, जसं याज्ञिक सरांनी स्ट्रेस केलं होतं, आणि त्यांच्यामध्ये इन्शुलिन सेन्सिटिव्हिटी आणि इन्शुलिन रेझिस्टन्स प्लस फास्टिंग जर इन्शुलिन लेवल्स बघितले तर त्या डिरेंज्ड होत्या. सो दॅट वॉज द बेसिक्स दॅट वी फाउंड. So yes, so what did we do ahead? What did these pregnancies lead? Low birth weight babies, small placentas, and again coming back to the Barker hypothesis, it wasn't a theory in journal now, it was life transmission of disadvantage from mother to child. But we found something even more subtle. Urine iodine was 84.6% micrograms per liter at delivery, which is critically low. What does that mean? So despite we have iodized namak, we are all having those into the national programs, but still we had critically low levels of iodine. So why does this matter? This matters because the deficiency of iodine in pregnancy, it reprograms the fetal thyroid function, which sets the metabolic thermostat of life. This is multi-generational micronutrient amnesia, wherein the body forgets how to be healthy. So yes, what did we do next? We followed up the neonates. We saw the children. We looked for 32,138 children, and we saw that 37% of them were stunted and 26% of them were wasted. So it is a total portrait of deprivation. To address this, we came up with something special from Derwan side, which we call the Derwan Laddus. They cater to 514 calories, and the picture changed. The baby started gaining weight. So obviously the stunted wasn't corrected, but wasting, yes, it was corrected. It is not a randomized control trial, but then we cannot disregard the findings that there were good changes that we saw with the introduction of these laddus. So yes, that's pretty much summarized in this slide as well. Moving on, we saw that we traced again the adolescent girls. there was this a fantastic study which was carried out in collaboration with MRC UK, which is the Talent Project, that is transforming life through adolescent nutrition, and Daron was one of its part, wherein we found out that we did qualitative study, and the challenges which were found out, and the answer to it was empowerment, and that is something we incorporated in the skill development programs of Day One. So yes, the adolescents. Something about Day One cohort. What is this cohort? In this cohort, we have adolescent girls, which we screen through their preconception, pregnancy, delivery, postnatal, and adult phases. And then what we do is we are following them up for their life. We don't leave them after the marriage. We also see them after their marriage, and then we track their children. So something which Yajnik sir already mentioned about, we are doing it in person, real time at Day One. This is the picture of the Day One cohort students. So yes, what was the hypothesis? Poor physical growth and nutrition during a girl's adolescence increases the risk of diabetes in adulthood and also in her offspring. So yes, we enrolled adolescent girls from three districts across three places: Chiplun, Sangameshwar, and Guhagar. These were the basic panel of the tests that are done for these adolescent girls. And then we follow them up annually post-marriage, during their antenatal visits, and also after delivery. Okay, so something stark that we found, we followed up 1,395 girls. We are still following them up. 63.4% have low BMI, 30.4% are stunted, and only 4.2% are overweight. But still, they have certain signs of diabetes. This is a clear picture of classic undernutrition. So, dietary diversity. If I ask you about your dietary diversity, I am sure it won't be as intriguing as the dietary diversity of these females. So mostly ह्या ज्या खातात मुली हा फक्त राईस आणि डाळ आहे किंवा चणे जे तिथे मिळतात. It is nothing more than that. It is nothing less than that. So the protein component or the green leafy vegetable component or the fruits component was clearly missing from their plate. So the median dietary diversity score was 3 out of 10. Most of them ate only 3 food groups in 24 hours. 86% of the females are vitamin D deficient. Their bones are starved from sunlight and nutrition. 41% have elevated lead. Their environment is poisoning them, clearly. 32% are B12 deficient, and 48% have high homocysteine levels. So this is what I called as microscopic famine, a famine of micronutrients at cellular level. But they had high cholesterol and LDL levels in the pre-diabetic group, and the dyslipidemia was almost 4% in the girls, and they had 12% had low HDL levels, leading me something called as metabolic syndrome. So we had 2.8% of the girls having metabolic syndrome as per the IDF criteria, and as per NCEP ATP3 criteria, we had only 1.8 of the girls having metabolic syndrome. So diving deep into the glycemic indices, this is something like a punchline which the glucose level have to tell us. 39% of the undernourished, thin, rural adolescent girls are pre-diabetic. When an OGTT was performed for 751 of them, 37.7% showed glucose intolerance. Their bodies were failing to process sugar, not because they ate too much of food, but because of too little capacity built over lifetime. So these are the BMI. Even in the thinnest girls, the BMI 12 to 16, their beta cell function is declining, their insulin resistance is rising, and their metabolic destiny is being written before they ever become mothers. So that is the unconventional path which I am trying to stress upon. So usually what we see is, we say that obesity in the urban group especially leads to diabetes, which is the conventional pathway. But something which we are seeing in Day One is that there is stark undernourishment, and that is leading to triggering NCDs. So coming on to the adult phase. Okay, so this is how the this is how the our patients look like. They are in their pre-diabetic phases, or say in the diabetic phases, wherein they were diagnosed for the first time. So this is not what you see. This is not a picture of someone who is having diabetes for a long time. They have been diagnosed with diabetes when they were lean. So I am here. I will present the data of our diabetic clinic, wherein we followed up 508 adults. They were lean, as I already showed. They had low BMI, but they had microvascular complications. 41% of them, and microvascular was seen in 18% of them. They have the devastating complications of diabetes without the obesity we are trained to look for. Their C peptides, as we can see, are low. This obviously suggests insulin in deficiency, and their pancreas is simply giving out. So that's what we have discovered. In effect, a new subtype, lean early onset deficiency driven diabetes. So to explain things and to put things into perspective, we see that overweight or obese, we generally see central obesity and adiposity present. In the group one, which I am here to stress on, they are underweight. They are obviously they're not overweight. There is no central obesity. There is no adiposity, but they still present with diabetes. All right. So coming on to conclude, I'm here to make to explain a basic theory, which is the unifying theory of capacity versus load framework, which Suvarna ma'am told me that she learned it from Yachnik sir. So I'm here to share it with you all. So how do we make sense of this paradox? मी काय म्हणते समजते सगळ्यांना की युजली ओबेसिटी हा ट्रिगर आहे डायबिटीजसाठी. पण आपल्या म्हणजे आमच्या ह्याच्यामध्ये आम्हाला दिसतंय की लीन लोक जी एकदम बारीक आहे, जी एकदम फिट आहे, दे आर हॅव्हिंग डायबिटीज. सो हा पॅराडॉक्स का आहे? सो याच्या मागचं कारण आहे मेटाबॉलिक कॅपॅसिटी वर्सेस मेटाबॉलिक लोड. What is metabolic load? Metabolic load is something which all of us go through in our lives. Say, for example, puberty, pregnancy, say even a simple carbohydrate meal, that is also a metabolic load. But what is metabolic capacity? It is what we are born with and build in early life. That is our beta cell reserve, organ size, metabolic resilience. So in these girls, the capacity is crippled by fetal programming, stunting, and micronutrient deficits. So the cycle is undernourished girl is going to be pre-diabetic adolescent, high risk pregnancy, low birth weight baby, and the next generation with even lower capacity. We have been treating diabetes as a disease of excess load. बरोबर आहे ना? आपण म्हणतो ओबेसिटी आहे म्हणून एक्सेस लोड म्हणून आपण डायबिटीजला ट्रीट करतो. पण इकडे क्लिअरली इट इज अ डिझीज ऑफ इनएडिक्वेट कॅपॅसिटी. So this changes everything. This also changes how we approach diabetes, because the drugs that we have to use are also going to change for tackling diabetes. So what is our duty? The same thing published. Okay, so what is our duty? Our duty is to build capacity with precision of engineers and the compassion of healers to screen the invisible, that is, look for diabetes risk, not in obese, but also in thin and stunted. Diagnose the mechanism. Don't just measure glucose, but measure insulin, C-peptide. In this, we need to question, is this insulin deficiency or resistance? The treatment is different. And then we need to prescribe specificity, not eat less, but eat B12, eat vitamin D, eat calcium, eat protein. Build the micronutrient foundation, like the Derwan Laddu did for us, and break the cycle at the door. Universal GDM screening in all pregnant women, regardless of their BMI. This is the most critical intervention point. So this is precision medicine in short for the poor, not with expensive gene sequences, but with a deep listening, intelligent nutrition, and relentless follow-up. So to conclude, I would like to say, we end where we begin. So we end with a choice. This work is guided by a searing truth. Those who suffer because of century-old beliefs are less guilty than those who are aware and do nothing. We are now aware. We are aware that diabetes has two faces, one of excess and one of inherited hunger. We are aware that the solution lies not in a newer drug, but in repairing the very architecture of human development. The girls of Konkan are not just patients, they are canaries in the coal mine of our collective metabolic health. Their bodies are telling us a story about the past and issuing a warning about our future. They have carried the inheritance of hunger. It is now our inheritance to break the chain. Thank you.
Thank you, Rachna ma'am, for such an impactful and insightful presentation. We'll now proceed with the paper presentation session, judged by Dr. Kavita Menon and Dr. Preeti Chavan. I invite Ms. Sajni Matthews from Dr. BMN College of Home Science to take over this session. Ma'am, over to you.
Good afternoon. Good afternoon, everyone. Welcome to the oral and e-poster session. Before we commence the session, there are a couple of guidelines that I would like to share with the participants. For the oral paper presentation, each presenter will have 7 minutes for their presentation. And at 6 minutes, you will be asked to wrap up your presentation in the next 1 minute. After 7 minutes, negative marking will start. This is for oral presentation. All the very best to everyone. I would now invite the first participant, that is code number 01, and her paper is titled Determinants of Placental Weight Among Lean Pregnant Women in India, Findings from the Pune Maternal Nutrition Study. Yes. Yeah, we can start. Should we start? Are you ready? Yeah, you can start.
Hello everyone, I am Shreya and I'll be presenting the findings from a project titled Determinants of Placental Weight Among Lean Rural Pregnant Women, Findings from the PMNS Study. So, let's start by talking about the placenta. So, placenta is a very crucial organ without which none of us would be here today, and it forms the bridge between fetal and maternal circulation. It has many important functions, but the key functions it performs is to facilitate the transport of oxygen between the mom and the baby. So, what factors determine placental development? There is a vast literature available on the maternal determinants. Papers have shown that maternal nutrition, age, height, weight, ferritin concentration, blood pressure, lipid concentration, exposure to passive smoking, maternal smoking, and the family's socioeconomic status influence placental development. Now, in terms of paternal variables, very few papers actually explore the effects of paternal variables on placental development. And this paper has shown that paternal BMI plays an important role in the placental development. So, keeping this research gap in mind, that very few papers show the influences of paternal characteristics, and the findings that I showed in this previous slide, most of these findings come from developed country population. So, keeping both these research gaps in mind, we developed an aim to examine the determinants of placental weight in pregnant female from the PMNS study. So, PMNS is a multi-generational longitudinal cohort study in which around 800 females from 6 different villages in Pune were followed at their baseline during the pregnancy and even at postpartum. But for the scope of my talk today, I'll be focusing on the baseline and pregnancy follow-ups of these females. So at baseline, their basic anthropometry, their family data, their demographic data, and the paternal height, weight, BMI, skin fold was measured. And in pregnancy, In early, mid, and late, their anthropometry was repeated. So again, height, weight, skin folds were measured. At early and mid pregnancy visits, their blood samples were collected for sugar and lipid analysis and micronutrient analysis. Their dietary data was collected, in which their total calorie intake, total carbohydrate intake, total fat intake, total protein intake was noted. Their physical activity data was also collected at early, mid, and late pregnancy. And at delivery, the placentas were measured, the babies were also weighed, and the baby's birth length was also measured. So, out of these 800 females, applying various inclusion and exclusion criteria for my project, we have finalized around 650 participants for this project. So, the main outcome that we wanted to study was placental weight, and we adjusted this placental weight for fetal sex and gestational age, and this was done by the residual method. So the main maternal exposures were maternal height, weight, waist circumference, skin fold thicknesses, maternal lipid concentration, sugar concentration, ferritin levels, B12 levels, folate levels, blood pressure, the dietary data, physical activity data, and exposure to passive smoking. In terms of paternal exposures, paternal BMI and paternal waist circumferences were the key paternal determinants. And the covariates in these cases, the standard of living index. So moving to the results now, this table shows the basic maternal, paternal, and neonatal variables and the medians. So we can see that the median maternal age is around 21 years and the median BMI is 17.8 kgs per meter square. So we can say that these females, they were lean, they were young, and they were underweight. Now, moving to the birth and neonatal outcomes, we see that the median placental weight is around 350 grams and the median birth weight is around 2.6 kgs. So, the babies and the placentas are small in this cohort. Next, we wanted to see the association of placental weight with various maternal and paternal baseline characteristics. So, we see that if the maternal age, maternal adiposity, and paternal BMI is higher, the placentas are bigger. And if the moms were exposed to passive smoking, the placentas also tend to be bigger. Now we wanted to see the association of placental weight with maternal pregnancy characteristics. So this table shows the association of placental weight with early pregnancy characteristics. So we see that ferritin is very significantly but negatively associated with placental weight. That means that in early pregnancy, the ferritin concentrations are lower, the placentas will be bigger. Now this table shows the mid-pregnancy characteristics. So we see that if the systolic blood pressure and ferritin concentration in mid-pregnancy are lower, the placentas were bigger. On the other hand, if triglyceride, cholesterol, and red cell folate levels are higher, the placentas were bigger. Now, in late pregnancy, if the diastolic blood pressure is lower, the placentas were bigger. And if the gestational weight gain is higher, the placentas were bigger. So to summarize everything that I have talked about, the key maternal determinants at pre-pregnancy are maternal age and adiposity. In pregnancy, lipids, blood pressure, ferritin concentration, red cell folate levels are the key maternal determinants. And in terms of paternal determinants, paternal BMI at baseline is one of the key determinants of placental weight. Moving to the strengths and limitations now. Strength that this is a prospective cohort study. So we have data collected at multiple time points, and this is a community-based study. So the findings from this study can be extrapolated to other communities as well. Limitation that this is an observational study, therefore the causality cannot be established. And one of the examples is the inverse association that we see between ferritin and placental weight. Ferritin and placental weight. So maternal iron is pulled by the fetus towards itself for better fetal growth, and to accommodate the needs of growing fetus, the placenta also increases in size. So we can conclude by saying that if we improve the maternal nutrition at preconception and throughout the pregnancy, it can help us better the birth outcomes by promoting better fetal and placental growth. I would like to thank my supervisor, Professor Yajnik, staff at Diabetes Unit. A special thank you to all the PMNS participants, and thank you all for listening.
Nice presentation.
Thank you.
And data seems to be very robust. I have a question related to statistics.
Sure,
There is
ma'am.
no mention about any of those methods you use for analysis.
Okay. So this is multiple linear regression. So what we did was we checked the correlations first, and after checking the correlations, all the variables that were correlated, we put them in univariable linear regression models, and all the variables that had a significance of less than 0.01 were clubbed together in various MLRA models. So each of this table is a separate MLRA model.
So I have no question, but if the audience has any question, any question? No? Okay, move towards.
Thank you.
I invite participants 02. Her paper is titled Role of Fatty Acids and Placental Fatty Acid Metabolites in Cognition and Anthropometric Measures of Children born to GDM Women.
Should I start now? Yes. Good afternoon, everyone. My name is Nikita Joshi. The title of my presentation is Role of Fatty Acids and Placental Fatty Acid Metabolites in Cognition and Anthropometric Measures of Children Born to GDM Women. We all know that gestational diabetes mellitus is a metabolic complication in pregnancy whose prevalence is on the rise. It exerts various long-term consequences on the offspring. However, the mechanisms behind this programming are unclear. It has been suggested that placenta acts as a tool for programming, and maternal nutrition is an important determinant of both placental as well as fetal development. Fatty acids are one of the key nutrients essential for both the placenta as well as the fetus. Fetus is dependent on the maternal supply of fatty acids via placenta, and inside the placenta, these fatty acids undergo various metabolic processes as per the requirements, like production of specialized pro-resolving mediators, activations of PPR, and fatty acid oxidation. Any imbalance in maternal fatty acid intake or placental fatty acid metabolism can affect the transfer of fatty acid towards the fetus, which in turn can affect the fetal growth and development. So this study focuses on maternal fatty acids and specialized pro-resolving mediators. So I'll quickly explain about the specialized pro-resolving mediators, which are the anti-inflammatory and pro-resolving metabolites of fatty acids. So ecos- in brief, omega-3 fatty acid like eicosapentaenoic acid is metabolized to produce E-series resolvins, while D-series resolvins and protectins are synthesized from docosahexaenoic acid, and arachidonic acid, which is an omega-6 fatty acid, is further synthesized to lipoxins. So these fatty acids and their metabolites, they are known to be involved in the regulation of various physiological processes such as inflammation. It has been suggested that placental fatty acid metabolism and transport can influence fetal growth and development. However, the findings regarding anthropometric measures and cognitive performance in children born to GDM women are contradictory, and the underlying mechanisms are unexplored. In view of this, the present study for the first time explores the role of maternal fatty acids, placental fatty acid metabolites in GDM, and whether it is related to cognitive performance and anthropometric measures in children. So the objectives of the study are to examine maternal erythrocyte fatty acid levels across gestation at 4 different time points in GDM and non-GDM women, to examine the placental levels of fatty acid specialized pro-resolving mediators like resolvins, lipoxins, protectins in above women, and to evaluate the anthropometric measures and cognitive performance of children born to this woman and its association with maternal fatty acids and placental fatty acid metabolites. So this study is a part of ICMR CAR study wherein women were recruited at early pregnancy and followed till delivery. GDM was diagnosed as per DIPSI guidelines, and 209 women with GDM and 207 non-GDM women were included in the study. Maternal erythrocyte fatty acid levels were estimated at 11 to 14 weeks, 18 to 22 weeks, 26 to 28 weeks, and at delivery using gas chromatograph. The just mentioned fatty acid specialized pro-resolving mediators were estimated using ELISA kits from placental tissue homogenate, and Kaufman assessment battery was used for the cognitive assessment. Coming towards the result, this table shows the maternal characteristics, and as we can see here, maternal age, BMI, systolic blood pressure, and trim placenta weight was found to be higher in GDM women. whereas baby length was found to be lower in the GDM group as compared to non-GDM. This table shows the maternal erythrocyte fatty acid levels. We examined total 15 different fatty acids, but due to the interest of time, here I am showing the important ones. And as we can see here, the levels of saturated fatty acids were higher, whereas polyunsaturated fatty acids, eicosapentaenoic acid, linoleic acid, arachidonic acid, and omega-6 fatty acids were found to be lower in GDM women at 18 to 22 and 26 to 28 weeks of gestation, suggesting the need of adequate levels of polyunsaturated fatty acids to reduce pregnancy complication. We then examined the placental levels of specialized pro-resolving mediators, and this study for the first time reports lower levels of resolving D1, D2, protecting D1, resolving E1, while higher levels of lipoxin A4 in GDM placentae as compared to the non-GDM. This table shows the anthropometric measures of children at 4 to 6 years of age, and it were found to be similar between the groups. As discussed earlier, Kaufman assessment battery was used for the assessment of cognitive tests, and it consists of various tests like Atlantis, conceptual thinking, word order triangles, and number recall, which covers various domains like learning, long-term memory, visual and simultaneous processing, short-term memory, and sequential processing. So the cognitive performance was also found to be similar in both the group. So the similar levels are possibly because of the increasing awareness in parents regarding the GDM and its consequences. We then examined the association of maternal fatty acids with anthropometric measures, and some of the fatty acids were found to be weakly associated with various anthropometric measures like skin fold measures and head circumference from early pregnancy, that is at 11 to 14 weeks. Similarly, these fatty acids were also weakly associated with some of the cognitive tests like conceptual thinking and Atlantis. We then examined the association of placental fatty acid metabolites, wherein we found weak negative association of these specialized pro-resolving mediators like resolvins and lipoxins with the anthropometric measures like waist circumference and skin folds. So to conclude, the altered placental levels of specialized pro-resolving mediators observed in the present study possibly indicates are possibly associated with the increased inflammation in GDM, and the maternal fatty acid status and placental fatty acid metabolites are associated with the anthropometric measures and cognitive performance in children. I would like to thank ICMR and DBT for funding the study participants, and I'm also thankful to ICMR for awarding me SRF. Thank you.
How do you explain the associations that you found between GDM and the baby length?
So, we did not found a between length. These are about the anthropometric measures. So we found association with skin fold measures and the BMI, head circumference.
There was something about baby length.
It was found to be lower in the GDM group, ma'am. So babies born to women with GDM, they were lower as compared to those born to non-GDM women.
I have a question regarding
Yes,
the
ma'am.
design.
Yes, ma'am.
You said cases and control, right?
Non-GDM and GDM women. Yes,
So
ma'am.
why is it 1:1? Why couldn't it be 1:2? That's a normal cases and control you use.
Sorry, ma'am, I did not get your question.
You have taken GDM and non-GDM
Yes,
1:1.
Yes, ma'am, 1:1 ratio.
It will have an impact on this study.
Yeah, ma'am, this sample size gives us the power of above 85%, around 87%. So I think it is good enough. This sample size is good enough.
Any questions? Any questions?
Discussion for 1 minute.
1 minute.
Thank you.
I now invite participant 03. Paper is titled Exploring the Role of Excess Maternal Vitamin B12 Supplementation on Offspring's Health in Later Life, that model.
Good afternoon, everyone. My name is Sunana Chetri, and my topic is exploring the role of excess maternal vitamin B12 supplementation on offspring health in later life in a rat model.
We all know that vitamin B12 is an important micronutrient during pregnancy, critical for the growth and development of the fetus. Abundant literature exists which demonstrate the adverse effect of vitamin B12 deficiency on pregnancy outcome, cognitive function, and cardiovascular risk. However, short-term and long-term consequences of maternal vitamin B12 supplementation, excess vitamin B12 supplementation are not studied. In recent animal study, it is demonstrated that excess vitamin B12 supplementation with a dose of 120 microgram per day results in the gut dysbiosis and leads to low-grade inflammation. Similarly, in our recent human study also, we have found higher plasma vitamin B12 level in the GDM women as compared to the non-GDM women. Therefore, there is a need to examine the effects of excess maternal vitamin B12 supplementation on pregnancy outcome and offspring health in adult life. In view of this, the objective of the current study are to examine the effect of excess maternal vitamin B12 supplementation on pregnancy outcome, maternal 1-carbon metabolite, fatty acid levels, and oxidative stress marker, that is MDA in DAMS, and to assess cognitive performance and cardiometabolic variables in the offspring at 3 months of age. Coming to the study design, it was initiated after the ethical approval. The female Vista rats were randomly divided into 3 groups: control group, intermediate group, and excess group, from pre-pregnancy to pregnancy period. The control group receive a control amount of vitamin B12, the intermediate group receive an intermediate level of vitamin B12, and the excess group receive excess level of vitamin B12. At the end of the pregnancy, half of the dams were dissected on day 20 of gestation to collect blood, liver, and brain, and pups were also dissected to collect placenta, liver, and brain. And half of the dams were allowed to deliver on day 20 of gestation, and their offsprings were followed till 3 months of age to assess cognitive performance and cardiometabolic variables in the later life. So the rationale behind these vitamin B12 supplementation is that RDA for vitamin B12 is 2.6 mg per day for the pregnant women. However, pregnant women are supplemented with a dose that contains 500 to 1000 mg per day, which is almost 320 times of the RDA. So in view of this, in this study, the control group received a dose of 0.375 mg per day, which is according to the AI 93 guidelines. The intermediate groups receive a dose of 1.5 mg per day, which is almost 4 times of the control group, and the excess group receive a dose of 120 mg per day, which is almost 320 times of the control group, similar to the dose received by the pregnant woman during the pregnancy. Coming to the methodology, folate, vitamin B12, and homocysteine estimated by CMI method. Fatty acid level was estimated by gas chromatograph method. Oxidative markers such as MDA was assessed using spectrophotometric assay. For the cardiometabolic variables, enzymatic method was used, and to assess the cognitive performance, Morris-Water maze test and radial 8-arm maze test was used. For the statistical analysis, one-way ANOVA followed by LSD was used. Coming to the result, pregnancy outcome, absolute and relative weight of dams on day 20 of gestation. Here we have found that weight gain was comparable between the groups. The relative dam brain weight was lower in the excess group in comparison to the control group, and no difference was observed in litter weight, litter size, and absolute and relative weight of the organs. We all know that vitamin B12 is an important factor in the 1-carbon cycle. So we have estimated different 1-carbon metabolites, where we have found, as expected, vitamin B12 level was higher in the intermediate and excess group in comparison to the control group. However, folate and homocysteine remain similar across the group. Vitamin B12 interacts with fatty acid in the 1-carbon cycle. So we have analyzed DAM fatty acid, in which we have found that in the erythrocyte, myristic and stearic acid was higher in the excess group in comparison to the control group. In the same group, we have found high saturated fatty acid. In contrast, omega-6 fatty acid, omega-6 to omega-3 ratio remains lower in the excess group in comparison to the control group. We all know that placenta is a tool for programming. So we have analyzed different placental fatty acid, in which we have found increased level of DGL and delta-6 desaturase index in the excess group as compared to the control group, indicator of severity risk in the later life. Fatty acid status can influence oxidative stress. So we have analyzed malonidialdehyde and oxidative stress marker in DAMS, where we have found higher plasma MDA levels in the excess group in comparison to the control group. This could possibly be due to the high saturated fatty acid found in the same group, which can trigger the lipid peroxidation. To assess the long-term effect of excess maternal vitamin B12 supplementation on offspring health, we have analyzed fatty acid from offspring, in which we have found that in the male offspring, total monounsaturated fatty acid was higher
while total omega-3, omega-6, and total polyunsaturated fatty acid was lower in the excess group in comparison to the control group. Whereas we did not find any significant difference in the female offspring at 3 months of age. We have also assessed cognitive performance in the offspring at 3 months of age using Morris-Water maze test and radial ATA maze test, in which we have found that in the Morris-Water maze test, we did not find any significant difference in both male and female offspring. Second, we have assessed using radial ATA-based test. This test is used to measure different type of errors. If an animal visited an arm without the food pellet, it is calculated as an error. So in this, we have found that in the male offspring, reference memory error and total number of errors were higher in the excess group in comparison to the control group. This could possibly due to the low omega-3 fatty acid found in the same group. While in the female offspring, only reference memory error was higher in the excess group as compared to the control group. Vitamin B12 is an important determinant for the cardiometabolic health. So we have assessed different cardiometabolic variables in which we have found that in the male offspring, triglyceride and VLDL cholesterol was higher in the excess group in comparison to the control group. While in the female offspring, we did not find any significant difference. This could possibly be due to the fact that sex hormones such as testosterone play an important role in the cardiometabolic health. Therefore, we have noticed sex-specific difference. To summarize, vitamin B12 supplementation increases erythrocyte SFA, placental delta 6 desaturase index, and MDA levels, and the offspring born to them have had poor cognitive performance and increased risk of CVD. To conclude my study, excess maternal vitamin B12 supplementation did not affect pregnancy outcome, but differentially influenced fatty acid levels and increased oxidative stress in dam, and impaired cognitive performance and increases risk of CVD in the male offspring. So the implication of this study is further animal and human studies are required to provide clues towards optimal supplementational strategies, as vitamin B12 don't have any upper intake level. Thank you.
Interesting study, actually.
Thank you so much.
So, when you looked at the fatty acid levels, you saw there is a difference in the saturated and the polyunsaturated.
Yes.
How would you account for these differences?
For the saturated fatty acid, actually, there's no reason for that. We did not find any reason for that. But vitamin B12 has play important role in the one carbon cycle, and it also interacts with fatty acid there. So it may influence fatty acid status in the one carbon cycle.
How about the unsaturated ones?
We don't have any reason because there are no studies with excess vitamin B12 supplementation. This is the first study which is examining the role of excess vitamin B12 supplementation with the fatty acid status.
Were there any changes in the offsprings visibly? I'm not talking about the experimentally.
No.
But, from the
No.
visible, no. They were all alert and
yes,
they were all good.
The weight gain was comparable across the group. So we did not find any difference. No, ma'am. Only when we did the cognitive assessment, they were little bit slow as compared to the control group. But as such, we did not find any differences.
How about fat concentration?
Ma'am, we did not measure fat concentration.
Anyone from the audience? Thank you. Thank you. Participant 4 is doing an online presentation. Her paper title is Formulation and Evaluation of a Phytoestrogen Enriched Nutraceutical Mix.
Am I audible?
Shukrani, you can share your screen.
Yes, ma'am. Is it visible?
Yeah.
Yes. Good afternoon, all. Myself, Dr. Shukrani Devan. I'm associate professor in JNMC College, Kahe, and the title of my paper is Formulation and Evaluation of Phytoestrogen Enriched Nutraceutical Mix. So phytoestrogens are plant-derived estrogen-like compounds, mainly lignin, which is present in linseed, and isoflavons in soybean. They are associated with hormonal regulation, antioxidant activity, and cardiovascular protection. So basically, linseed has a secoisolyracyl residue diglucoside (SDG). It is metabolized to enterolignans further, and soybean has genistein and benzene, acting as a selective estrogen receptor modulator, beneficial for menopausal health and bone density. So linseed and soy phytoestrogen nutrimix together offers synergistic benefits by improving lipid metabolism, reducing oxidative stress, and supporting So objective of this paper is to formulate and evaluate phytoestrogen enriched nutraceutical mix incorporating linseed and soybean together. So basically this research focuses on assessing its nutritional profile, anti-nutritional components, and storage stability. Raw material used was linseed Jawar 77, soybean MHCH 58, and black gram Virat category, procured locally, clean, stored in airtight containers. Processing techniques like drying, roasting, milling was applied to obtain meal and flour, and 3 formulations were in the ratios of 80s to 10s to 10, 60, 30, 10, conducted by using a periodic scale. Nutritional analysis was carried out for nutrient profile along with that moisture and ash by standard methods. Anti-nutritional factors like phytic acid, trypsin inhibitor activity, tannins were analyzed. Shelf life study was conducted for Tetra packs and polythene packs for a room temperature for a period of 1 to 3 months. And cost analysis was also carried out, and statistical analysis was expressed in a mean plus minus standard deviation and pair t test. So linseed, that is also called as Ursian Zawar, is proteins, antioxidants that improve nutrition and shelf stability. So their synergy together supports cardiac health and oxidative protection, yet combined use is limited. So hence phytoestrogenic nutrimix was developed and evaluated for the same. Formulation and preparation of phytoestrogen enriched nutraceutical mix with the different variations given in this table. Roasted linseed in the combination of 40, 30, and 20. Roasted soy flour 15 and 5, and roasted bengal flour 15 and 5. Organoleptic evaluation of this nutraceutical mix showed that overall acceptability of second sample, which contained 30 gram of roasted linseed, 50 gram of roasted soy flour, and 5 gram of roasted bengal gram, was the highest. If we compare before processing, after processing, only moisture content was changed statistically significantly. Otherwise, other parameters were unchanged. The change was statistically non-significant. Energy, as we say, this nutraceutical mix is rich in nutrients. It provides 363 kilocalories, 27.5 gram of protein, and calcium 180 mg, iron 4.98 mg, total dietary fiber 25.3, omega 3 8097.59 mg, and omega 6 content was 5059.78 mg. Anti-nutritional factors, if you see, cyanogenic glucosides and phytic acid change significantly after processing in the final product. The shelf life stability, if we compare, Petra packaging had better stability after 3 months as compared to the polythene packaging. Cost calculation was carried out. The cost of total 1 kg of this nutraceutical mix was 120 rupees. So in a discussion, we can say that the phytoestrogen enriched nutraceutical mix containing 30 gram roasted linseed, 15 gram roasted soy flour, 5 gram of roasted bengal flour showed the highest sensory acceptability, consistent with reports of improved organelle quality in nutraceutical supplements in a previous studies. Nutraceutical mix retained sensory quality after for 1 month in polythene pack, but up to 3 months in the Tetra packaging. It was a cost effective as compared to the market products. The similar RTS health mixes have demonstrated high protein, calcium, and iron content with a good storage stability in previous studies. So overall, the nutraceutical mix appears to be a promising nutrition supplement for postmenopausal women and PCOS patients, warranting further long-term evaluation. In a conclusion, we can say that this is a nutrient-rich supplement high in energy, protein, iron, calcium, fiber, and omega-3 and 6 fatty acids. Processing reduce cyanogenic glycosides and phytic acids significantly with minimal impact on tannin and trypsin inhibitors. Tetra packaging is quality better than polythene packaging. Treatment can be utilized for postmenopausal women or the treatment of PCOS as a nutraceutical base. These are the references for this study. Thank you.
Thank you, Dr. Devan. Am I audible to you?
Yes, ma'am.
Okay,
Yes,
thank you for
ma'am.
the presentation. It was nice to see some food-based studies coming in. I have a question. You said it is a phytoestrogen-rich supplement. Did you measure the quantity of phytoestrogen in your product?
Actually, that was a problem. Getting a standard solution of phytoestrogen for a HPLC is very difficult in India. If you check all the references and published articles on the same researches, getting a standard solution is the biggest problem here. Lignin and even dead zinc and other factors, other phytoestrogen content.
Thank you.
Hello, Dr. Shukrani. Which guidelines were followed for the stability studies?
Shelf stability.
Yes, yes. So did you follow any guidelines?
For shelf life stability, we do sensory evaluation after 1 month and after 3 months for both the type of packaging, tetra packaging and polythene packaging. We check sensory. I'll show you if you want, the slide.
Yeah, so how was the sensory quality study?
On the basis of 9-point hedonic scale, we perform sensory evaluation, and the expert panel of sensory evaluators, like food technologists, they perform the test. Texture, taste, smell.
Thank you. Next, we invite participant 05. Her topic is fatty acid status in adolescents born to mothers with preeclampsia.
Good afternoon. Good afternoon, everyone. My name is Bhargavi Patel, and good afternoon, everyone. My name is Bhargavi Patel. The topic of my study is fatty acid status in adolescents born to mothers with preeclampsia. To begin with, preeclampsia is a hypertensive disorder which occurs during pregnancy. It is a placental pathophysiology which involves trophoblast invasion and leads to poor placentation. It is also known to lead to adverse birth outcomes and increases the risk for neurodevelopmental disorders in the children in later life. However, the mechanisms for these are not clear. Literature also suggests that fatty acids play an important role in placental and fetal brain growth and development. However, our earlier departmental studies in preeclampsia have demonstrated altered maternal and placental fatty acid metabolism. These placental changes may affect the fatty acid status of the children, and since adolescence is a critical age where biological and physiological changes take place, it is important to understand whether these placental changes affect the fatty acids status in adolescents who are born to mothers with preeclampsia. So, the objectives of the study are to compare the dietary omega-3 fatty acid intake between adolescents born to mothers with and without preeclampsia, to compare the fatty acid status between the adolescents, between these adolescents, and to compare the fatty acid status gender-wise between adolescents who are born to mothers with and without preeclampsia. Coming to the study design, mother and childbearer were recruited at the time of delivery in 2006 to 2015 at Bharati Hospital, Pune, wherein their clinical and biochemical data were collected. For the current follow-up study, we have taken the data for dietary patterns, physical activities, anthropometry, cognitive performance, and biochemical. And for the biochemical and molecular estimation, the blood samples were collected. And currently, these children are in their adolescent period. From the age group of 11 to 18 years. Ethics approval was taken and the study was substantially powered. For the methodology, dietary intake was assessed using food frequency questionnaire, wherein we focused on the omega-3 intake of the adolescents. Their erythrocyte fatty acid levels were also estimated, wherein we estimated about 15 fatty acids, saturated fatty acids, monounsaturated fatty acids, polyunsaturated fatty acids, in which omega-6 and omega-3 fatty acids were also estimated using gas chromatography. For statistical analysis, considering the literature stating young and late adolescent periods, we stratified these adolescents for different age groups, under 14 and over 14. And the comparisons were done using SPSS software. Coming to the results, for the adolescent characteristics, for the adolescents who are born to mothers with preeclampsia, showed higher weight and BMI, and the results remain consistent, especially after the age stratification in the over 14 age groups. For the omega-3 fatty acid intake, the dietary intake were comparable. For the adolescent fatty acid levels, after stratifying for age, under 14 adolescents who were born to mothers with preeclampsia showed higher DPA, NA, total omega-3 fatty acid levels, along with omega-6 to omega-3 ratio being lower. For the age group above 14 years of age, the levels of myristic, palmitic, and DHA levels were seen to be lower, with GLA, DGLA, and delta 6 desaturases being higher. So here we can see differential fatty acid levels as per age, which can be attributed to various demographic, lifestyle, or hormonal changes which are introduced in the adolescent period. Next, we stratified them gender-wise, wherein we only found lower levels of myristic acid in adolescent girls who are born to mothers with preeclampsia. Coming to the adolescent fatty acid levels, wherein we stratified them age as well as gender-wise, wherein we saw that adolescent girls who are born to mothers with preeclampsia and who are under 14 years of age had comparable levels except for NA, and over 14 girls had higher levels of AA, omega-6 to omega-3 ratio with lower DHA levels. In boys, we saw under 14 boys, we saw higher levels of DPA, and in over 14 boys, we saw higher levels of DGLA, delta 6 desaturase levels, and lower levels of palmitoleic and the delta 5 desaturase levels. So to conclude, age and gender specific differences were seen, fatty acid differences were seen in adolescents who had intrauterine exposure to preeclampsia, thereby suggesting further implications for the risk of neurodevelopment or cognitive performance in later life. Hence, it is important that there needs to be further studies done to understand the relation between the fatty acid profile with the cognitive functioning in adolescents born to mothers with preeclampsia. I would like to acknowledge Department of Biotechnology India and subjects recruited at Bharati Hospital, Pune. These are the references. Thank you.
Interesting study.
Thank you.
I don't have any questions. I have a couple of questions. Were the questionnaires validated?
Yes, ma'am. It was
What was the callback alpha?
Ma'am, it was a self-reported questionnaire. Ma'am, I'll get back to you. Like we've
Another
done.
important thing is that, like the questionnaire, FFQ, whenever you use,
Yes,
is it a semi-quantitative or quantitative? What is that you have used? That information is needed.
Okay, ma'am. Ma'am, yes.
Because then the capture of values from the food will vary.
Yes.
And because this is like a kind of follow-up of a cohort that you are talking, even the supplements that they consume in between also have an impact on
Yes, ma'am. Ma'am, for this study, we've mainly focused on their omega-3 level status. Thank you.
I invite our next participant, number 6, maternal and her paper title is Maternal and Cord Fatty Acids and Anthropometric Measures in Adolescents.
Thank you, ma'am. Good afternoon, everyone. My name is Vrushali. I'm from Yesha Bharati Vidyapit, Pune. The title of my study is Maternal and Cord Fatty Acid and Anthropometric Measures in Adolescents. As we all know, maternal nutritional status, especially fatty acids, are crucial for the fetoplacental growth and development. Altered levels of these fatty acids during pregnancy are linked with the adverse pregnancy outcomes like low birth weight and small for gestational age babies, that is SJ. SJ is defined as the birth weight below 10 percentiles for their gestational age. It affects 36% neonates in India and 23% globally. These SJ-born children carries high risk of non-communicable diseases in later life. Despite the high prevalence of SGA and distinct thin phenotype, what we have learned in the afternoon, the research specifically on the role of fatty acid in the fetal development remains limited because there are most of the studies which are on the Western population, often cross-sectional, and there is a very much limited research in Asian population with the distinct dietary patterns and metabolic responses. To the best of our knowledge, no study has explored the relationship between maternal fatty acid and longitudinal changes in anthropometry from childhood to adolescence. Based on this, the objective of the study is first to compare the maternal and cord fatty acids among the mothers delivering SGA and AGA babies. Second, to compare the anthropometric measures of children born to this mother. And third, to evaluate the association of these fatty acids with anthropometric measures of children at 3 to 7 and 11 to 17 years. This is the study design for the present study, where mother and child pair were recruited at the time of delivery from Bharti Hospital, Pune. At that time, maternal and cord blood samples were collected along with the maternal neonatal demographic and other information. Follow-ups were conducted at 3 to 7 and 11 to 17 years. At both the time points, detailed anthropometric measure, food index through food frequency questionnaire, and physical activity levels were collected. The study was ethically approved by the ethical committee, and written maternal consent and adolescent assent were taken from the participants. This flowchart explains the recruitment process. Total of 2 to 7, 3 mother and child pair were recruited in the year 507 children were followed at the age of 11 to 17 years. At each time point, we have divided these children into SJ and AGA. AGA is appropriate to gestational age as per their birth weight. Further, as the growth and development of these children are not uniform in the early and late adolescence, we have classified our data into below and above 14 years to account for the developmental transition and age-based variability. This classification done by the Tanner scale, which actually gives us idea about the different pubertal stages. Even to assess the gender-wise specification, we have classified our data into male and female. Coming towards the result, when we compare the maternal characteristics among the mothers delivering SGA and AGA, we found that the mothers of SGA were shorter, had lower BMI, and with the higher blood pressure. Similarly, neonates born SGA were anthropometrically smaller in size compared to AGA pairs. Our main focus from all the nutrients were fatty acids. Hence, with the help of gas chromatography, we have analyzed 15 fatty acids, which we have clubbed under the saturated, mono, and polyunsaturated fatty acids, that is PUFA. Among the PUFA, omega-6 and omega-3 get converted into AA and DHA respectively with the presence of enzyme delta-6 desaturase and delta-5 desaturase, which we have calculated with this formula. These enzymes were considered as markers of a lipid metabolism, inflammation, and later life adiposity. What the result shows that we found that the mothers delivering HGA were having higher MUFA, delta-6 desaturase index, and lower LA and total N6, indicating maternal diet low in PUFA. In contrast of that, we found that HGA mother were having, cord of HGA mother were having higher DHA and total N3. This could possibly due to placental biomagnification. Then we try and assess the risk of HGA birth, and we found that maternal low PUFA and high MUFA and delta-6 desaturase level were associated with the higher risk of HGA birth. Then we compare the anthropometric measures of children born SGA and AGA at the age of 3 to 7. And we found that SGA born had lower BMI, all the body circumferences, and skin folds, indicating different growth than the children born AGA. A linear regression model was run to assess the association of fatty acids with children in the at the age of 3 to 7. At this stage, model 1 we have considered as unadjusted, and model 2 was adjusted for the birth weight, maternal age, BMI, income, education, parity, and preeclampsia status. And we found that maternal N6 to N3 ratio was positively associated with the skin fold, indicating fatty acid play a key role in determining adiposity at the age of 3 to 7. Similarly, our data also demonstrate that the cod delta 6 desaturase was positively associated with the skin folds, indicating greater risk of obesity in early childhood. Further, we compared the anthropometric measures of these same children at the age of 11 to 17 years, and we found that SGA-born children still had the lower BMI and body circumferences at the age of 11 to 17, indicating they continue to be smaller throughout the childhood. But at this stage, their skin folds were comparable, indicating more adiposity and thin fat phenotype. Then we assess the association of fatty acid at the latter ages, that is at the greater than 14 years. Here at this stage, model 2 was further adjusted for the pubertal developmental scale to assess the puberty as well. And the result shows that increased maternal saturated fatty acids were associated with higher BMI, western hip circumference, and skin folds. Similarly, higher maternal N6 to N3 ratio was also associated with the higher hip circumferences, indicating fatty acid during pregnancy may exert lasting effect on the offspring body composition. Increased PUFA was inversely associated with the skin folds. Cod showed that the higher cod MUFA and delta 6 desaturase associated with the greater hip and waist circumferences. These associations were not seen in the younger adolescent, and gender-wise association of a maternal fatty acid profile and child anthropometric outcomes were similar. Key findings from the study are lower maternal PUFA, higher MUFA and delta 6 were associated with the increased risk of SGA birth. SGA children remain smaller throughout the childhood and adolescence. Higher maternal N6 to N3 ratio and cord delta 6 index were positively associated with the skin folds at 3 to 7 years. At the latter ages, maternal SFA N6 to N3 ratio and delta 6 were positively associated with the waist and hip circumference and skin folds. PUFA showed inverse association with the skin fold, and hence we conclude that maternal and cord fatty acid levels are associated with the anthropometric measurements in the childhood and adolescence. Longitudinal anthropometric measurements of SGA-born children is the unique strength for this study. This is the unique prospective cohort linking maternal and cord fatty acids and adolescent anthropometry and ability to capture the long-term impact of fatty acids on offspring adiposity. Limitations are we haven't able to use the DEXA for the body composition analysis, and fatty acids were analyzed only at the time of delivery. At the end, I would like to acknowledge the DBT for funding this project, all the participants, staff, and listeners. Thank you.
Interesting study.
Thank you,
I have
ma'am.
similar questions. How did you validate your food frequency testing?
Ma'am, actually for this study, the study what I have presented, we haven't incorporated any intake data. The whatever results I have shown about the fatty acid, that was, yeah, that was from the plasma fatty acid. It is not from the intake. But definitely we have taken the dietary recalls and we have taken the food frequency questionnaire. It's only the frequency, we haven't quantified it. It is not the semi-quantitative or quantitative. We just taken the frequency, but in my data, I haven't incorporated the intake yet.
But it was mentioned in the letter.
Yet we are actually in the pipeline to analyze the data, yet dietary intakes are not incorporated in this.
So did you find any difference between the SGA adolescents, meaning adolescents who were born as SGA and AGA in terms of their body composition?
Yes, ma'am. The data showed that they are small in size. Even visually, they are appealing small in size. Their height, weight, BMI, everything was smaller compared to their ages. So that was the first eye-appealing difference what we can make out. And even the data showed that at the age of 3 to 7 and 11 to 17 years, both the time we got the same results. Thank you.
Thank you.
With that, we conclude the oral presentation and we move on to the e-poster presentation. The guidelines for e-poster presentation is the participants have 3 minutes. 2 minutes you will be given a warning and within 3 minutes you have to wrap or there will be negative marking. So I invite participant number 1. Our topic is anemia among rural women of reproductive age from Mulshi Taluka, Pune during the third wave of COVID-19 pandemic?
Do we start, ma'am? You can start.
Okay. Good evening, all. I am Pooja Panchal from Symbiosis School of Culinary Arts and Nutritional Sciences. The research topic for is anemia among rural women of reproductive age from Murshi Taluka, Pune during third wave of COVID-19 pandemic. You might be thinking anemia is so common. Why again? So today morning, Dr. Anuradha ma'am did say that okay, by 2025 we were to reach the targets, but have we reached? No, we have not. So the study focused on the unheard difficulties for health and diet, especially for women of reproductive age, the primordial and the preconception women of reproductive age from Murshi Taluka, Pune. The major objectives was to identify the determinants, what are the factors leading to anemia, especially in women of reproductive age from Murshi Taluka. A study, it was a cross-sectional study using proportionate to population size sampling method from 23 villages of Murshi Taluka, and it was the sample size was 303 women without any COVID-19 symptomatic conditions, apparently healthy and not having any medications or are on special diets. The ethical approval was taken from Symbiosis along with Directorate of Health Services, Ministry of Women and Child Development, Maharashtra, as it was a community-based study. The total collection approach was 3-day visit. First day, we collected the pre-structured questionnaires on socio-economic and demographic information of the participants, followed by general hygiene and food preparation practices and wash practices. The second day, when we visited, we collected the anthropometric data, and the biological specimen collection was done from the trained phlebotomist using icing protocol, specifically for blood. And the data was collected during July 2021 and January 2022. The anemia classification was majorly based on hemoglobin less than 12.9 grams per deciliter according to WHO classifications, and the data was statistically analyzed using SPSS software, and descriptive analysis was followed by bivariate and multivariate stepwise forward linear regression analysis. The results showed that the mean age of the population was 25.7 to 3.5 SD years of age. Okay. And almost 40% of the females were anemic in my population who had high iron deficiency anemia. The major factors that were observed using regression model was total household monthly income, menstrual cramps, food preparation practices. And I would like to conclude that anemia remains a silent threat to rural women of Mulshi Taluka. And to tackle this pressing issue, targeted interventions focused on nutrition, health education, and improving living conditions are essential. Thank you.
Did you have any range for the
Yes,
women?
18 to 30 years of age.
Why did you choose this specific?
Because we wanted to see the preconception status, nutritional status of the women before they get pregnant.
So none of them were
Non-pregnant, non-lactating.
There was no
Yes, yes.
Did you find anything about menstrual? I mean, in terms of reproductive health and their menstrual loss of blood, etc.
Yes, yes, it was statistically significant, and plus they had hemorrhoids due to constipation. So that was also one of the reasons for
What percent? What percent?
10% of the women had constipation with hemorrhoids as well, and that lead to major anemia problem.
Only 10%.
Yes, 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 yes.
Why were they anemic?
Due to diet, different types of diet which I have not shown over here, plus household income was one of the factors which was related to it, and also they did not have any supplements which was provided during that period of time to women.
Do you feel everybody has to take a supplement in order to be
No.
having a good
No,
income
no,
or
no,
whatever?
no.
Then
Yes, but as it was COVID period and the movements was very restricted, so whatever they consume was according to the agriculture production which they. That was the reason.
Thank you.
Thank you.
I now call upon participant number 2. Her poster title is Influence of Dietary Zinc and Iron Intake During Pregnancy on the Risk of Preeclampsia.
Shall I start?
Yes.
Good afternoon, all of you. I am Vaishnavi Mudgal, and my topic is influence of dietary zinc and iron intake during pregnancy on the risk of preeclampsia. Preeclampsia is a pregnancy-specific hypertensive disorder, and it has short and long-term consequences to both the woman and the offspring. The micronutrients are essential, plays very important role during pregnancy. Zinc and iron are essential micronutrients which are required for fetoplacental development and fetal growth. If there is any deficiency or imbalance occur in this nutrient, it may lead to pregnancy complications like preeclampsia. And there are limited studies explored the dietary intake of these nutrients in association with the risk of preeclampsia. Therefore, this study aims to examine the association of maternal dietary zinc and iron intake with the risk of developing preeclampsia. And to address this, we have conducted a cohort study including 681 mother and child pair recruited at the time of delivery at Bharti Hospital, Pune. Ethical approval was obtained from Institutional Ethical Committee. In this 681 mother and child pair, 192 were diagnosed with preeclampsia, and we have collected extensive data where we have collected maternal characteristics, anthropometric measures, clinical data, and dietary data using a validated food frequency questionnaire. The data which we have collected was qualitative type. We have also noted neonatal anthropometric measures including birth weight, length, and head circumference. And coming towards the result, we found that women with preeclampsia had higher mean systolic and diastolic blood pressure, BMI, and lower mean maternal age. With respect to neonatal characteristics, we found those born to mothers with preeclampsia had lower birth weight and smaller head circumference compared with control. We found that women with preeclampsia had lower consumption of iron-rich food sources compared with control, and zinc-rich food sources consumption was also lower in preeclampsia group compared with control, but it was not statistically significant. We have also looked into some association, and we found that women consuming iron-rich food sources reduced odds of preeclampsia, and women consuming iron-rich food sources, it was positively associated with maternal hemoglobin level and neonatal birth weight. So to conclude, reduced intake of iron during pregnancy is associated with increased risk of preeclampsia. So there is a need to encourage pregnant women for consuming iron-rich diets from early pregnancy to reduce pregnancy complications like preeclampsia. Thank you so much, and I would like to thank DBT for funding this project, all my co-authors and subjects for their invaluable participation. Thank you so much.
Thank you. We will not be taking any questions. I invite participant 3. Her poster is titled Maternal Vitamin D Deficiency is Associated with Placental Endoglin Levels in Women with Gestational Diabetes Mellitus.
Okay. Good afternoon, everyone. I'm Dr. Juhi Neema. The title of my presentation is Maternal Vitamin D Deficiencies Associated with Placental Endoglin Levels in Women with Gestational Diabetes Mellitus. Gestational diabetes mellitus is characterized with endothelial dysfunction, which is generally regulated by various angiogenic factors, including soluble endoglin. Vitamin D, as we all know, has an important role to play during placental development as it regulates critical processes such as angiogenesis and inflammation during pregnancy. Vitamin D deficiency has been associated with risk of pregnancy complications, and study examining vitamin D levels in GDM women were mainly cross-sectional, and they report contradictory finding. There is no longitudinal study which has examined the relationship between vitamin D levels across gestation in women with GDM. we have earlier demonstrated that vitamin D status will influence soluble endocrine level in women with GDM. Therefore, in view of this, this study aims to examine the association of maternal vitamin D status with placental endocrine levels in women with GDM and non-GDM women. This study was a part of ICMR revamp study, in which pregnant women were recruited at 11 to 14 weeks of gestation, and they were followed up at 18 to 22 weeks, at 26 to 28 weeks, and at the time of delivery. Serum vitamin D levels were estimated at all the 4 time points during gestation using commercially available ELISA kits, and soluble endocrine levels were estimated from the placenta using ELISA kit. To compare the vitamin D and endocrine levels between the groups, we have used independent t-test, and to examine the association between various variable, multiple linear regression was used. Now, coming to the results, women who had GDM had higher BMI and higher glucose levels. Babies who are born to mother with GDM had higher birth weight, and their trimmed placental weight were also higher. When we examined the placental soluble endocrine levels in women with GDM and non-GDM, we found them to be similar between the groups. However, when we looked into the levels of vitamin D across gestation, we found that vitamin D in the GDM group at V3, that is at 26 to 28 weeks of gestation, was significantly lower as compared to non-GDM group. We have also looked into the association of maternal vitamin D concentration with placental soluble endocrine level, and we found a negative correlation both at V2, that is 18 to 22 weeks of gestation, and at the time of delivery. So, to conclude the finding of this study reports the influence of maternal vitamin D status on placental angiogenesis, suggesting an important role of vitamin D in the placental development in the GDM woman. Thank you.
Thank you so much. I now invite participant 5, and her poster title is Association of Selenium Intake During Pregnancy with Risk of Low Birth Weight. She is participant number 5.
Good afternoon. I'm Shabri Kare. My topic is association of selenium intake during pregnancy with risk of low birth weight. So selenium, one of the important micronutrient, is involved in regulation of antioxidant activity, thyroid hormone metabolism, and immune process. So adequate maternal selenium intake during pregnancy helps in maintaining placental function and thereby ensuring the fetal growth. Deficiency in the same during pregnancy is linked with adverse pregnancy outcomes like low birth weight. Limited studies have examined dietary selenium intake during pregnancy with respect to birth weight, and none of the study is done longitudinally. So this study, for the first time, examines the longitudinal effect of maternal dietary selenium intake with the risk of low birth weight. In the view of this, 1096 singleton pregnant women were recruited at Bharti and Gupta Hospital, Pune, out of which 915 women delivered normal birth weight babies and 181 women delivered low birth weight babies. 80 pregnant women delivering normal birth weight babies and 80 pregnant women delivering low birth weight babies were considered for this study. A validated food frequency questionnaire was recorded at 3 different gestational time points, that is 11 to 14 weeks of gestation, 18 to 22 weeks, 26 to 28 weeks of gestation, which included selenium rich foods like wheat, lentils, pulses, nuts, oil seeds, eggs, etc. Coming towards the results, maternal weight and BMI was lower among mothers who delivered low birth weight babies across all time points. Frequency of consumption of selenium-rich food was lower among mothers delivering low birth weight babies at 26 to 28 weeks of gestation. This was confirmed when we saw the association that the risk of delivering low birth weight babies was among the mothers at 26 to 28 weeks of gestation. So the study concludes that lower maternal selenium intake during 26 to 28 weeks of gestation is linked to increased risk of delivering low birth weight infants. So these findings emphasizes the need to ensure adequate selenium intakes through nutrition counseling and balanced diet. I would like to thank ICMR for funding this project and subjects for their valuable participation. Thank you.
Thank you so much. I now invite the next participant, number 6, and her poster title is Assessment of Dietary Patterns and Diet Quality Among Public School Children aged 10 to 12 years from Mumbai.
Shravani. You have to share. So good evening everyone. Myself Shravani More and I'm from Dr. BMN College of Home Science, Mumbai. The title of my study is Assessment of Dietary Patterns and Diet Quality Among Public School Children aged 10 to 12 years from Mumbai. So starting with introduction, adolescence, particularly 10 to 12 years, is a critical growth phase which is characterized by increased nutritional requirement. Children from public school are highly exposed to ultra processed food, and despite of the food availability, diet quality gaps often remain hidden, and therefore assessing their dietary pattern is essential for early intervention. The aim of the study is to assess the dietary patterns and diet quality of 10 to 12 years old children studying in public schools of Mumbai suburbs using a food frequency questionnaire and a 7-day individual dietary diversity score. The study design was a cross sectional study including 200 children from two public schools in Mumbai suburbs, and the parental consent form was obtained before the data collection. Tools used were food frequency questionnaire including 40 food items and a 7-day individual dietary diversity score covering 12 food groups. In statistical analysis, gender-wise differences were analyzed using independent sample t-test and age-wise variations were examined using one-way ANOVA. So in the results section, in the gist of participant characteristics, overall 200 participants from both the school was recruited, out of which 110 were boys and 90 were girls, and the mean age was 11 years, which contributed to 50%. So looking at the food frequency questionnaire, the overall participant reported increased consumption of staples like rice, poha, milk, followed by chapati, paratha, rava items, and dals, and they reported lower consumption of micronutrient-rich foods such as green leafy vegetables and sprouts. When comparison between boys and girls were done, boys reported increased consumption of chicken, pizza, burger, pasta, which was statistically significant, and girls reported increased consumption of other vegetables, which was also statistically significant. Now, looking at the 7-day individual diet diversity score, the overall participant reported a high diet diversity, and this was attributed to school management that provided meal when they observed nutritional gaps in the children's. And between the boys and girls and across the age group, there was no statistically significant difference that was observed. So, in conclusion, despite adequate overall diet diversity, diet quality gaps persist, and high intake of energy dense and low micronutrient rich food intake highlights the need for school based nutrition initiatives. These are the reference, and I would like to thank Department of Food Science and Nutrition from Dr. BMN College of Home Science, Mumbai, school authorities, participating students, and parents. Thank you.
Thank you. I would like to call upon participant number 7 and her posthumous title, Placental Fatty Acids and Gene Expression of Transcription Factor and Fatty Acid Transporters in Assisted Reproductive Technology Pregnancies.
Good afternoon, everyone. Myself, Aishwarya Kabre, and the title of my presentation is Placental Fatty Acid and Gene Expression of Transcription Factors and Fatty Acid Transporters in Assisted Reproductive Technology, that is ART pregnancies. ART, including IVF, IUI, used to treat infertility, and the prevalence of infertility is on the rise in India. According to the literature, ART procedures are linked with placental dysfunction and may impact fetal growth and thereby long-term health. Fatty acids are known to regulate gene expression and signaling pathways which are which are important for placental development. Therefore, we aim to examine the fatty acid levels and mRNA expression of transcription factors, including PPR gamma and HIF1 alpha and fatty acid transporters such as FATP1 and FATP4 from the placenta of ART and non-ART pregnancies, and to explore the association of fatty acid status with gene expression and birth outcome. This study includes 93 women conceived naturally and 64 women undergone ART procedures. Maternal blood and placental samples were collected at delivery. 15 placental fatty acids were estimated by using gas chromatography, and gene expression was carried out by using quantitative real-time PCR. Moving towards the results, maternal age and diastolic blood pressure was higher, whereas gestational age and birth weight of the neonate was lower in ART women. In the placental fatty acid levels, we observed that total omega-3 fatty acids were lower, whereas omega-6 to omega-3 fatty acid ratio was higher in ART group, indicating imbalance ratio of omega-6 to omega-3 fatty acids may promote inflammatory effect which affect the birth outcome. In the placental gene expression level, PPR gamma and HIF1 alpha was found to be lower in ART group. PPR gamma is known to involved in various processes, including implantation, placentation, and trophoblast differentiation. And HIF-1 alpha is known to regulate angiogenic factors, and the reduced levels indicates impaired placentation in ART pregnancies. Along with transcription factors, FATP1 and FATP4 was found to be lower in ART pregnancies, which alters the transport of fatty acid towards the fetus, which affects the fetal growth and development. We were also interested in the association of placental fatty acid levels with placental mRNA expression, and we observed that placental LA was positively associated with PPR gamma, and whereas placental GLA was negatively associated with PPR gamma and FATP4. In the association of placental fatty acid levels with birth outcome, we observed that placental AA, omega-6 and total PUFA levels were negatively associated with placental weight and birth weight. To conclude, ART procedures are associated with disturbed placental fatty acid metabolism, which influences placental weight and thereby birth outcome. Additionally, reduced expression of transcription factors and fatty acid transporters in ART placentas may impair placental development and fetal growth. I would like to acknowledge DBT for funding this project and patients for participating in this study. Thank you.
That was the last, right?
Yeah.
Last poster.
I had to rush through the poster session. That's mainly because the Mumbai team has to leave, otherwise we are going to get delayed. So I would like to thank all of you for patiently sitting through the whole day. It's been a long day. I think the sessions were really back to back for those who have been here. But I think I'm very happy that in such large numbers, students especially were able to come. It's fantastic. I would like to say we work a lot in mother and child health. We have 3 different cohorts which are going on, a lot of biochemical and molecular mechanisms, which integrate with the nutrition. So anybody of you is interested at any time point, you can come visit our lab. Today will be too rushed possibly. But any other day you all want to come, you want to see the recommend with an ICMR. Collaborating Center of Excellence, we also have the Center of Advanced Research. So anybody wants to understand what is the scope of nutrition in something other than because hardcore nutrition we are already doing, you are most welcome anytime. Just give us a call. We definitely see that you are able to do that. So I think thanks a lot. Yeah, conclude. Yes. Thank you so much. I think ma'am has given us the concluding remarks. As the host college and of course the collaborating partner with Dr. Joshi ma'am, it is my proud privilege to propose the vote of thanks. We are doing it before because I know you are all going to anxiously wait, and especially the oral presenters as well as the poster presenters, but bear with us for 2 minutes. This is very important because functions and events like this do take a lot of efforts. And it's really very important to thank all the people who got together in order to arrange this entire enriching day for all of us. I start by thanking Dr. Mishra and the authorities at Bharatiya Vidyapit, Dean to the university. I really would like all of you to please give a round of applause to Dr. Krishna and her team of the Mother and Child Health ICMR Collaborating Center of Excellence, Irsha Pune, for enabling this collaboration and hosting this conference at this wonderful venue. Thank you so much, ma'am. Many thanks to our keynote speaker, Dr. Yajnik. I think we were privileged to have him here with us, along with all the other speakers who also gave us wonderful sessions. I specifically thank Dr. Krishnaveni, Dr. Basak, who has traveled specifically for us, Dr. Panikar, Dr. Dwarkanath, Dr. Datar, for the in-depth sessions that I'm sure gave you a lot of enlightening information and knowledge. And I especially also thank, one more round of applause definitely for our speakers as well as for our judges. Thank you Dr. Menon and Dr. Saman for helping us judge the poster presentations and the oral presentations. I think none of the events are really going to happen unless and until we have participants like you. I think this should be the round of applause. So thank you dear participants for your enthusiastic participation and being a part of this event today. I would like to especially thank Dr. Aditi. You will see she has been standing here at the helm the entire day for hosting this entire event. I also wish to place thanks to the administrative and the technical team here at RUSA, and in fact also at both the institutions, that is Dr. BMN College of Home Science. I cannot go without thanking my home institution, and therefore at home, I am really very thankful to our management members, we are Seva Mandal Education Society, and to our dear principal, Dr. Mala Pandula, who is with us every step of the way. So thank you to them for being pillars of strength. Yesterday, I came to Asia for the first time. But let me honestly tell you from Dr. Harsha Chopra, who has been the convener of this conference along with Dr. Joshi. Okay, I have heard so much about them. Yesterday, I only put faces to names, but I felt as if I already belonged. So thank you so much for making our team feel really wonderful. The team of people who are a part of Sabnaman's team have worked tirelessly for the entire event. This has not just been planned in the last 2 days, but it has been ongoing from November. And so a big thank you to all the team members of the at the Department of BMN, I am blessed. I have Dr. Harsha with me, who coordinates the nutrition and dietetics program. She's the one who took the lead and said, ma'am, let's do it. And so thank you, Harsha, for enabling this. I also have three very important team members, Ms. Madhura Gaisas, Ms. Sajni Matthews, who's coordinated, and Ms. Arundhati Lahiri, quietly sitting in the audience, but they have been pillars of strength. They have worked tirelessly, all the registration forms, etc., all the work that was being done at the institution of BMN. Thank you to all the three members. I don't think we could have done it without you. Well, so we've come to the end. I do hope I have thanked everybody. In case in this entire day's work that has gone in, if I have left out anybody, I would really like to place thanks to all of them. Big events like this, I know cannot happen without the effort of every small and every bit that is done for it. So thank you to one and all. I just leave you with this thought that for each petal of the rose, this brings a wish your way, good health, because that's what we have done today. Good health, good luck and happiness for today and always. So thank you very much. And just like Sadhana ma'am said, if you are at Mumbai, and if you do, please come to Matunda. We are at the center of Mumbai. Dr. BMN College of Home Science will always welcome you. Thank you so much. We would really love to have your feedback, and I do hope. I think this entire screen, which is full of that particular code. There are a lot of students in the audience. Come on, quickly remove your mobile. I suppose it's in your hand already. So just scan the code and give us your feedback. It's very important. We did our best, but we would like to know how much we reached you. So please do the needful for the students. Unless feedback is filled, certificate will not be handed. Thank you so much. We request Dr. Vasak and Dr. Lakana to please give away the prizes for the oral and the poster presentation.
We had an amazing round of presentations today, showcasing thoughtful research, innovation, and scientific rigor. And now it's time to reward them. So for the best oral presentation, I'd like to call Ms. Vrishali Kadam.
Congratulations. Thank you so much for doing this. Thank you so much for doing
And the award for the best e-poster presentation goes to the poster titled Maternal Vitamin D Deficiency is Associated with Placental Endocrine Levels in Women with Gestational Diabetes Mellitus by Dr. Juhi Neema.
so that you can take a photo with both experts. Yeah, Vishali also.
नहीं नहीं